So we're now in the process where we have some discussions. I'm sure all of you in the room, you could relate to all the topics which were presented. You could all relate to patients presented, and I'm sure you can all relate to scenarios where we got stuck as cardiac surgeons in one way or the other, or as anesthetist, or as cardiologists. So let's start with some questions, please. Yes, please. Just identify yourself, please.
I'm Sunil Budia from Harefield Hospital. So I just wanted to make other people jealous that we've got quite a lot of people from Harefield here. Uli Stock is from Harefield now, though he's showing us the weather in Perth, but certainly he enjoyed Harefield with us. But just to give you some examples of what we've been doing, and I think some of the privileged centers like us, Harefield, Newcastle, Papworth, we should be discussing some of the cases, the successes of some of these cases. And I can tell you a case we did with Vas Panoulas, where I'd done a tricuspid valve repair and the patient ended up with right heart failure, young patient. I think if I was in a different center, probably would have just called it and said, that's it, we can't do anything more. But Vas came and put an impeller in that patient. And after a few days, impeller came out and patient went home. Recently, with the speed, we had a patient who had VSD, and electively we just decided to come these patients off ECMO. Whether they come off nicely, we still put them on ECMO 48 hours, and then wean the ECMO off. And that's the strategy we've been following. And I think these are the cases we should be discussing with the rest of the community so that they can understand what sort of cases they can take forward for mechanical support.
So I think what we learned from all the four speakers is fundamentally that it's not about the highly specialized centers, that everything which had been presented, maybe with a very few exceptions, can be done everywhere. And I think, to me, the most important message, and this is maybe something for the society to take on, especially to generate more appetite in discussing MCS in general, and it's not about, forget about transplant. This has nothing to do with transplant, and this has not even something to do with durable LVADs. This is something which we have to embark more and more because of this, and I think we need to learn that there is something out there beyond intra-aortic balloon pump. More questions? Yes, please.
Just a couple of comments. I think, first of all, thank you very much for excellent talks. They were all very illuminative. I certainly made lots of notes. I learned a lot from it. Because I am not a transplant surgeon, and I work in a center where we do have ECMO available for post-cardiotomy, cardiogenic shock, but we use it very stringently, as it should be. I mean, we've got policies about how we need to take it out of the hands of the invested surgeon because there's the emotional element of it and have an MDT and so on and so forth. Anyway. But I think in general, in the UK, we probably have a 3-tier service for post-cardiotomy support. One is the patients who are in centers where ECMO is a commissioned service, where the threshold for putting the patients on ECMO is quite low. And perhaps there's some things to be discussed about whether it should be that low and whether that's a good use of resources. The second is those where there is a in-house cardio post-PCCS service available and where patients can be put on them with some stringent discussion and perhaps with some interaction with the local transplant center. And then obviously the third element where there isn't any access available at all. I think in order to make this a more uniform service across the country, perhaps what is required is, A, as you quite rightly say, and we heard from the speakers as well, about the joint societies having a position statement about this to support practitioners in doing what they need to do, but also perhaps more important, the more experienced transplant centers actually providing adequate support to the non-transplant centers to manage their resource implications and work as networks. You know, at the end of the day, UK is a small country where perhaps 6 or 7 networks would be sufficient to serve the whole country. And I think that's the kind of model perhaps one should start working towards, because it is very difficult to get individual centers to have a number of patients on ECMO because the resource implications and the opportunity costs are tremendous if you're not a commissioned center. I think there's lots of logistical issues, but there's no question that this is a service which should be perhaps more equitably available to all patients across the country.
But Manoj, just let me just come in there. Is maybe this impeller technology, is that something in between which could allow us, put the balloon pump aside, use the impeller, get the patient on the offloading strategy for a little bit, for transfer, because the transfer with an impeller is straightforward. It's not as complicated as impellers, and then move to a, more sort of one of our tertiary centers where you can potentially even add ECMO if needed.
Yeah, perhaps that is an excellent, could be a strategy going forward. I am not aware, and I'll be happy to be educated about the presence of impeller in the UK and how widespread it is. To my understanding, it's not particularly widespread, but perhaps others on the panel could, or in the audience could tell me a little bit more.
So just sharing an experience from Glasgow, we didn't have an access to the impeller, especially the impeller CP by the cardiologist, although we do have quite a high number of interventions, and thereby they worked with us in terms of transplant service, and then we came up where the cardiologist became more proficient at putting on the guide wires and keeping the patient ready. So by the time the crash call for the ECMO comes in, everyone's alerted and pretty much the wires are in. Then it's just a question of putting in the cannulas and going early on ECMO in these patients. And we've demonstrated 52% survival in these patients. So it is possible. Impeller, it is expensive as well as it requires technical expertise. And in terms of the non-transplant centers to embark upon a journey of the mechanical cardiac support, it's important for us to keep it simple and it's more easily accessible. Cardiac surgeons put patients on bypass every day. And for them to put the patient on ECMO, I think it's more easily doable, and then to embark upon a different technique to begin with. Eventually, of course, impeller will come and take over. As the cardiologists are getting more and more experience with the impeller CPs, I believe it is there, and we won't be able to sort of stop it. But
can we hear the anesthetic view?
Yeah, I want to say thanks very much for some really quite inspiring talks. And as well as anesthesia, I also do critical care and ECMO. And I set up the Bristol ECMO service. And so I sit on the National Respiratory ECMO Network meetings. And it's a breath of fresh air to hear these discussions because, as we talked about, networks are not that difficult to make in a small country. And there exists that exact provision for respiratory ECMO. And we in the ECMO fraternity have slightly been knocking our heads together because although today we're talking about a specific type of ECMO support, there is difficulty in getting commissioning support for VA ECMO because it encompasses things including eCPR where the outcomes are difficult to prove outside of single-center studies. And so I think the strength of this meeting and discussing it in this forum is that actually we can go back to the commissioners and say, actually, there is appetite to this. The cardiac centers would be happy to align themselves with that. Because the other part of the journey is that because it's networked, that has a certain protectionism to it. So the centers that do it are the centers that do it, and that's not widely shared. But we've recently set up a new ECMO center in Bristol. It's gone reasonably well with a mentored program. I can't see why something else wouldn't be possible across the board for cardiac surgery.
I mean, what I learned from some of the talks, especially Bastian's talk about the high-risk cardiac surgery, I think that might be just another, another sort of introduction of new technology because all of us, we have high-risk patients in front of us. One center may be more than other center, but we all have specific patients with poor ejection fraction, mitral regurgitation, a bit of diabetes, overweight, poor lung function, and we all know that they are discussed at MDTs and they're quoted a fairly substantial risk of not coming through. And some of us might even say no to those patients at all. And I think, what I learned from this, actually a beautiful video, by the way, I learned how simple it in fact could be. Yes, of course, you're an experienced center with the impellers, but it looked really simple in terms of surgical implantation technique and the console. I think that was quite convincing to me, and just want to hear some of the audience's view on this. Please, stand up.
Thank you very much. Good morning for everybody. I'm Sandil from Coventry. It's a really interesting talk, Professor Schuler and Professor Ulrich. And as we discussed that the ECMO centers, I think it's so easy to say that create ECMO centers. But every time when we face with this situation, I'm sure Sunil will agree with me, is the commissioning for VA ECMO is a problem. So quite a few occasions we discussed this with the nearby ECMO centers who will look after these patients, what is the cost implication. That's the one thing. Another thing is, as Harry said, putting ECMO is not an easy job, it's not a difficult job, but carrying them and supporting the team with the clinical governance impacts onto it is very important, I think. I think we are good in making a position paper and statements, but when it comes to pragmatically looking at it, I think it's pleased to hear that mentoring program with the Bristol was good. I wish every centers in the country, cardiac center, who takes the high-risk cases will have the same service. I think we should work on it, and more centers would be happy to participate. Thank you.
But would you mind asking me a question? So listen to the talks. You, in your environment, would you have now, listening to the simplicity of this impeller, for example, in this high-risk mitral, would you go home and discuss it with your colleagues? Would you be more sort of empowered to do that kind of stuff?
Prof, thank you very much. It's a very interesting, provoking question. I'm pleased to know that impeller from femoral is abandoned now, pretty much. That is a one step. Impeller itself is an evolving technology. I mean, having worked in few centers and seen few of those. The fact is, I think we, at Coventry in my center, coming to a question, is we are in the process of initiating a shock team and ECMO, and we have got a protocols in place. And the question comes that economic implications, right? After 3 days, will any center take up? I'm sure that all the transplant centers except few are here. So it would be direct question, apologies.
Can I just come in? Sandil, I think the point that you're raising is an absolutely important point in terms of, we live in a time with a very limited resource right now. Every service is trying to squeeze what is not there from the pot to try and access. I think important message here is that previously when we used to see the long-term outcome of the MCS patients, I think these talks have, one of the important point has been about optimization of the patients using Impella 5.5 and then essentially having a successful outcome and a long-term successful outcome of these patients. So I think rather than having a postcode lottery for the patients not to have the access to a good health care, I think it is important that the take-home message is that this is something which is definitely helpful. We have to work within that limited resource that we have and how best we can do that. That's what Manoj he alluded to the point that there has to be that collaboration with the regional transplant center in terms of having that support and taking this forward.
Oh, thank you, Harry. I really respect that. What I'm requesting to society people like Manoj and all is basically to just, along with the paper, just make some mentor program and connect some centers and make it work. That's what I'm requesting. Thank you very much.
Thank you very much, Senthil. I just wanted to just go back to that because, yes, it is having a system where you can manage the patient as a whole is quite a big and it's extremely expensive. However, I think what this use of impeller is giving is a start to think about what you're going to do with the patient. Because what we usually get is that we get a shock call where we discuss numerous people, about 10 to 20 people, discussing a patient, whether or not they're going to be suitable for this, suitable for that, whether they're going to be suitable even for transplant, as much as that. But what impeller is adding, and what we are trying to give the message, is that before you even do that, you have got a resource that you could use, which is the impeller. So you can put the patient on that, and then you can think in the light of the day, reduce the use of all those resources that would be used immediately by just using the impeller, which is a much cheaper option compared to using all of those other things.
I think that was an excellent comment, Speed. I think that's a very important message to take this home here, I think. I would like, is there anyone of the nurses' colleagues amongst us here to stand up and tell us what their view is on this?
Yeah, so I'm from Papworth, so we are an ECMO centre. I guess we can talk about putting the devices in the first place, but that's just the first step, isn't it? We're talking about how do we care for these patients when they're on the intensive care. If you're a low-volume centre and don't see these devices very often, how do you ensure that your nursing staff, your AHPs remain competent in using these devices? Because ultimately, it will fail if you haven't got staff who know how to use it.
Okay, I think the concept about this is you're exactly right. I think that actually the way to view this, and I know that Vaz and Alex have done this at the Harefield, is you've got to build this from the ground up. The mechanical support is the top of the pyramid. You have to tidy up your cardiogenic shock provision for all comers, be they Sky, BA, tidy those things up, have protocols in place for your vasoactives, and you have to clearly stratify your patients into risk groups and also pathophysiological groups, because there's a difference in outcomes depending. So I think if you embark on this program, it can't be with the idea, no offense to Biomeds, of just buying some machines and hoping for the best, because exactly as Vaz said, it just doesn't work that way. No. So you have to build it from the ground up, and I think if there was a kind of working paper that suggested, you know, the steps to which you achieve this, because the low and medium volume argument is one that I have to defend every day. Yeah. So I think it's I think that's a really important point.
I mean, you know, what we'd like to achieve today, that no one in this audience would go home scared about this technology, right? We would like to encourage you to go home and say, well, I want to look into this because I want to find something beyond the balloon pump. And I think that is probably the message we would like to convey to, you know, everyone, nurses, anesthetists, cardiologists, surgeons, and even administrators if they're here. So I think we're done today. I think what I'd like to tell you, there's a lunch symposium which is organized on impellers. You might as well stick your head in. You will hear more talks. You might be able to have your hands on the device as such. And I think maybe we can take it from here, and for maybe next year we can follow up on this.
Yes, perhaps we can. And it's about setting out the stall first to say that this is a possibility. I think we shouldn't ignore the practicalities and the logistics of it, because it is really important. I mean, in our experience, the opportunity cost for one patient on ECMO for the duration of the 3 or 4 days they might be on ECMO in a non-ECMO center is about 15 to 20 cardiac cases. Because we have to remember, in non-ECMO centers, ECMO has to be managed by perfusionists and they get taken out of the equation. So I think there are lots of issues which need, it's not impossible, but it's certainly, the logistical challenges are significant. They have to be taken on board, but there's certainly a need to make progress in this domain in the UK, because as we all know, there's a bit of postcode lottery here.
But you know, looking at the age of this, the audience here, I'm probably the oldest one, but all of these guys need something for their professional future to deal with. So just go home, do something about it. Thank you very much for coming. Thank you. Thank you.
Just everyone.
One
more thing, please.
One tiny little thing for a second.
Right. Can I just ask everyone to go to your apps and just score our presenters. Just give a feedback on our presenters. Each of the presenters will have a session. Please do that. Don't forget. Thank you.